An official good evening to everyone. Unfortunately, I can't seem to get my camera to work, which I'm quite sad. I washed my hair and everything, but let's get going. So my name is Liza De Beer, and I'm the brand manager at HealthBridge, and I'll be your host for this evening. I'm excited to be part of this webinar this evening, as due to COVID-19, we've been approached by a number of our clients with questions around how they could better manage the business side of their practice during these difficult times. So we put together this webinar to answer some of these questions, and I'm hoping that at the end, you'll walk away with some really great tools and tips to truly help your practice thrive. It's now just past 7 p.m. and we are going to get going shortly. So for those of you who've just joined us, if you haven't already, please take a few seconds to complete the poll on your screen. I see we've had over close to 30 now participants complete the poll. While we wait for more participants to join, I thought it might be of interest to give everyone a feel for the room. We currently have 66 delegates who have joined us so far. We've had almost 100 registrations for this webinar, of which 82% of you are general practitioners. Other specialities joining us tonight include psychologists, physiotherapists, family physicians, pharmacists, nurses, pediatricians, physicians, occupational therapists, and podiatrists. So a really nice spread of specialities. Great. And now I want to bring your attention to some general house rules. If you have a question, please feel free to send it using the Q&A feature. We will try to answer as many questions as we go, and you should be able to find the Q&A feature down at the bottom of your screen. Secondly, if after the webinar you would like someone to call you back, please email webinar@healthbridge.coza. Simply include your name and preferred contact number in the email, and if you have a specific question, you can include that too. Either way, we will call you back. This is a CPD accredited webinar, therefore your entrance and exit is automatically recorded. To obtain your certificate, please ensure you stay for the full duration. You will receive your certificate by email within approximately the next 2 days, or give us until Monday. Great, so with the admin out of the way, let's get started. I would like to introduce you to our speaker for this evening, Louis De Silva. Louis De Silva is the MD of HealthBridge. In addition to leading HealthBridge and ensuring that the company remains focused on helping medical professionals to provide good patient care and run good businesses, Louis is an amazing storyteller. Louis De Silva has been asked to present on a range of topics to different industry stakeholders, including the impact of the strained economy on healthcare patient behavior, trends impacting ICD-10 coding, the importance of context in data-driven insights, and the digitized doctor's room of the future, to name a few. And so it is at this point that I would like to hand over to Louis so that we can get the show on the road.
Thank you, Liza. Wow, best bring my A game after an interview, after an introduction like that. To everybody, a very big welcome and thank you for joining us this evening at 7 o'clock on a Wednesday. The webinar will be an hour long, and through this hour we'll be doing a deep dive into how we see the impact of COVID-19 on you as medical professionals, but particularly on the business side of your lives. So without further ado, I'm going to share my screen. And Liza, maybe you can give me a heads up when you see it.
Perfect, it's there.
Great. Okay, so inoculating the business of your practice against COVID-19, that really is going to be the topic of today. And from an agenda perspective, there are really three big chunks that I'd like to address. Firstly, some trends that we see during COVID-19, really through all the data that we have running through our systems from various specialities that we serve. Secondly, based on those trends, the impacts that we see happening on practices on a daily basis, both now and into the future over the next couple of months. And then very importantly, given these trends and these impacts, hopefully some practical and ethical steps that can be taken to address ultimately what is revenue shortfalls in your practice right now. And then lastly, we'll end up with a conclusion. Firstly, however, thank you for those that took the poll. And Liza, perhaps it would be a great time if you could just share with us the results of the poll. Thank you. So 87% of our respondents with us tonight have said that patient volumes have dropped. 8% no real impact. 3% of practices are still closed. And it's great to see that 53% of our respondents are offering some form of telehealth in terms of consultations, which is very encouraging to see. You'll see later, given how we see one of the options to bolster your practice. Thank you, Liza, and thank you to all of those who responded. That's great. Right, so let's start off with some trends from our data warehouse in an aggregated and kind of way. What are the trends that we've seen over this COVID period? And the first thing I'm going to look at is across all the disciplines that we serve, ranging from the general practitioners to specialists, allieds, dentists, optometrists, all of that kind of averaged over this time. And through these slides, you'll see a bit of a time frame. The data that we're going to be showing is as of last Sunday, the 26th of July, really working back on a weekly basis and to the week just before lockdown was announced, which was 19 weeks ago. Can you believe it? That's been almost... yeah, we're really through winter, and next week we're in August already. It's incredible. Importantly, you'll see the markers of when lockdown was first initiated, then the extension, then the relaxation into level 4, then the relaxation into level 3. And those little stars under those weeks are important because during those weeks there were either 1 or 2 public holidays, depending on the number of stars, which of course skews the volumes for that particular week and needs to be taken into consideration. So if we look over this period, you will see that the week before lockdown was announced, we've used that as our reference week, really anchoring that at 100% of volumes at a weekly basis across all disciplines. And then we've really played that out up to last week, which you see ended up at 83%. And not surprisingly, the week before lockdown was announced, already there was a bit of a drop. Then lockdown came in and immediately you saw the drop in patient encounters. And as soon as level 4 was announced and came into being, the volumes picked up quite significantly. Overall, there was a good pickup after level 3, but importantly, you can see that even now, we are trading at about 83% of pre-lockdown volumes. So on average, a good comeback after lockdown, sort of ramping up to the 83% levels. What I'd like to now do is look at the different specialities, because each different speciality really tells a different story. And the first ones I'd like to look at, and particularly since there are so many general practitioners with us today, is what did we see on average across all our general practitioner clients. And what we see is obviously during the lockdown a drop, the step jump up in level 4, the step jump up after level 3, and then a really good kind of increase. But interestingly and quite alarmingly, last week, just after the previous week of achieving a 90% with reference to pre-lockdown volumes, the volumes have slipped back to 83%. And we'll talk to that a little bit more later, but one of the key things is we do see some of the practices, just given where the peak of COVID is, having to shut down for a week or a couple of days, either because of a COVID case or in fact a doctor or staff being infected, and that obviously disrupts the practice for that period. And overall, as an average, therefore, it stands to reason that the GP volumes have dropped, particularly in this last week as we really get into the thick of COVID nationwide. When we look at optometry volumes, well, particularly given that in essence optometrists trade in malls, a very different story. They were completely emaciated over those first couple of weeks up to level 4, with then a good step up thereafter. And the volumes have actually been quite strong since then, not quite at pre-COVID times. And the volumes really towards the end of this period is to be expected as benefits run out, start running out. Certainly the seasonality of optometry is a lot earlier than other specialities, and therefore somewhat to be expected towards those last 3 weeks or so of this time frame. Dental volumes, a similar pattern, although not as extreme during the lockdown period. A good pickup, and certainly right now a good recovery and quite robust actually over this time period. The next one I'd like to talk about is allied volumes, and this also has a different story. Surprisingly robust during the lockdown period, the first phase and the extension of lockdown. In fact, the most robust discipline over that time. And then been a bit variable over time. But as of late of last week, certainly very strong at the 95% level. Of course, there's a blend of specialities in the term allied, so one could double click and look at different areas specifically. Specialist volumes tell a very interesting story. The initial sort of drop in volumes, a good steady recovery, but as you can see, they've stagnated at the 76 odd %. Now, specialist again is a very suitcasey statement. Certainly you get the big breakup of specialists that are typically consulting versus those that end up operating. And so what I thought would be interesting is to look at the surgeons, the surgeon volumes. And I think the biggest trend we can see is certainly towards the end of the period, the volumes starting to drop quite dramatically, never got to the volumes of the other disciplines, and certainly over the last while, at least the last week, a severe drop. And I suspect this is really due to obviously hospital beds being more and more allocated for COVID patients, and therefore very little theatre space, and really only the very, very urgent operations that need to be done are done, and as a result, those volumes dropping off. Plastic surgeons are an interesting story. The story I tell myself is that because of this high volatility, really, I guess, making use of available capacity on an ongoing basis, perhaps liaising directly with hospitals, and really trying to make use of any capacity before the storm of COVID hitting. And thus you see this quite volatile pattern over the time. Pathology volumes on a different level. Initially quite a knock, but as can be expected over the last couple of weeks, very strong, in fact higher than the initial volumes. And of course we know that private pathology labs have taken a bigger part in COVID tests, and thus we can expect as a result that these volumes are higher than what would have normally been anticipated. On the radiology side, also initially a big knock, some good recovery towards the end, and what we're seeing is more and more things like chest x-rays starting to come through, again obviously related to suspected COVID conditions. And then lastly, the one I'd like to share with you is anaesthetists, and this is quite interesting because despite the number of operations clearly going down, anaesthetists, if anything, are slowly edging up. And that really is a blend of, on the one hand, the number of operations that they need to attend to dropping, but as we know, they are heavily involved in ICU cases related to COVID, and as a result, their volumes actually picking up for an unexpected reason compared to what one would have thought at the beginning of this year. So I hope that gives a good general kind of overview on how the volumes by disciplines and many other categories we could have covered. But I just wanted to give everybody a sense of volumes, and you might be looking back and wondering or reflecting on how closely this actually kind of corresponds to your own personal experience over this time period. Another important factor that we track during this time is how are virtual consults being done. And the fact is, if you look at pre-COVID, certainly there's been a marked increase in virtual consults, be they telephonic or video. But the reality is that as a percentage of total volume, still very, very low. The mainstream is still absolutely face-to-face consults. However, I will show you later that some really early adopters have embraced this and have really been able to make a big difference to their practice as a result. We also track the difference between video consults and telephonic consults in terms of virtual consults. And here you see it's quite a squiggly line. It breaks up, first of all, scheduled versus walk-ins. Those are the bar graphs. And then the lines really talk about telephonic or versus video. And you can see the green line being the video consults. Pretty much straight after level 4 was announced, that started reducing quite markedly. Back in fact to levels more or less, or if not a little bit under the telephonic. Those lines are on a per day basis, and that's why they move quite a bit. Obviously Saturdays and Sundays being quite low, but it gives you a sense of the general trend, which is video consults certainly over the last while have dropped quite a bit, as opposed to during the strict lockdown periods. One last bit is that on a very aggregated level, certainly counselling was one of the highest reasons for virtual consults, as you can understand. If you take out the orange, which is a big reason for particularly telephonic consults in the past, which is for the issue of repeat scripts, a lot of the other sections start coming into the view of from a counselling perspective. Again, at a aggregated level. So this was the last 18, 19 weeks. What do we think is going to happen for the next while, let's say from now until the end of the year? And I guess it's everybody's guess. Everybody tends to be a specialist. Everybody's got a piece of research backed by a number of scientists. So who really knows? But this is our view, just given the trend that we've seen, and in fact how we've modeled our business in terms of our own expectation over the next couple of months. The reality is that the normal volumes are unlikely to return for 2020. And from our perspective, we think that an average of an 85% volume from now until the end of the year, based on what was previously expected, would in fact be a very good outcome. And why is that? Firstly, we're in a situation where obviously COVID-19 is peaking. So we might not have the lockdowns, but patients will again want to stay away from practices, particularly those that are really ill and have got comorbidities because of obviously fear of contracting COVID. At the same time, ironically, higher at-risk patients will need to be proactively engaged with. If you've got a patient that's got diabetes, those repeat visits and care is absolutely important. And ironically, just at a time where for an extended period of time, maybe this patient or these patients haven't been to see you. And then, of course, the frontline staff, you as doctors and your staff, will continue to be affected in one way or another, just given how great at risk you are. The other dimension to consider is, in fact, that we just speaking to schemes, and just the other day I was speaking to a very senior person at an administrator, and certainly there is the expectation that scheme membership will contract. Firstly, already trends in terms of buy downs, just given the pinch for consumers. And secondly, as a result of job losses, the initial estimates were at least at about 4% contraction for next year. But I suspect it's likely to be worse as the reality of the financial impact starts coming across our society. And then, of course, why 85% for the full year? Well, we know as the year begins to end, and hopefully as COVID begins to ease, so we hit the typical year-end seasonality. Which, although one could argue there might be some pent-up benefits left, just we know towards end of November and certainly December, depending again on the specialities, not so much pathology and hospital and radiology, but pretty much all the other specialities, the number of patient encounters start dropping just naturally. It's amazing how little people get sick when they're on holiday, for example. And perhaps this year will be the same. So there's really two dynamics to manage. On the one side, COVID, I think, will affect practices, continue to affect practices over the next couple of months. And hopefully, as we see those storms lifting, let's say by October, the impact of seasonality starts hitting in. And so this really presents quite a financial challenge for practices over the next while. So on impact on practices, what does it all amount to? Here's a calculation which was done by myself. It really lends on the Council for Medical Schemes report for 2018-2019, the latest available. I extrapolated it based on the average medical aid inflation. And I really took a look at this general curve which I showed you initially, and really figured out what is that spare capacity or that loss of patient encounters, that loss of revenue, and what does that account for across the industry-wide, not just our clients, but at an industry level, across all general practitioners, specialist dentists, and allies. And the number is quite staggering. Over the last 18 weeks, practitioners have lost 7.2 billion rands collectively in revenue. That is a staggering number. Of course, across the whole industry, but nevertheless, that is a very, very big number. And on the end of that, if one assumes that my assumption is correct of the 85% of volumes left from August to December, that's going to equate to another 4 billion of revenue loss. So a really big and deep impact to medical practitioners and the businesses of medical practitioners. That's really what this amounts to at the end of the day. And I guess for me, doing them numbers and calculating it really made it tangible as to the extent of it. And so it's no surprise that we see articles like this where private healthcare practitioners talking to medical schemes saying, listen, you haven't been hit heavily at the moment because the claims have dried up. Let's do some sort of arrangement, give us a bit of a facility and claw back against it over time as hopefully volumes recoup. Really, the cash flow crunch on practices, while some costs still stay in that practice, be it rent or whatnot, has been severe in many cases. And what this country doesn't need is already the scarce practices that we've got to be closing down for financial reasons. So what are these shortfall revenue drivers? Well, I think they're quite clear. Obviously the lockdown, patients scared to come back to practices even after lockdown. Another one is just the strict sanitization processes within practices that are required, the way the workflows of practices have had to change. That ultimately reduces patient flow through, and that in the end has got obviously an impact on revenue. And obviously for specialists and the like, then the hospital bed capacity planning is a big issue. I spoke to the CEO of a big hospital group just last week, and really on a daily basis, he personally is actively engaged on bed capacity planning by hospital, just given the trends as they're doing with this fine balance of ensuring there's enough capacity for COVID patients, while at the same time trying to maximize the beds and the operating theatres to treat patients outside of COVID. A real horrible task and a hard task on a daily basis for, in fact, even the CEOs of these big hospital groups right now, or in fact any other hospital group. So these are really some of the key drivers. The other impact on practices, of course, is the increase of bad debt risk. And why do I say this? Well, shockingly, we're over the 30% unemployment rate as of June, and that's set to climb. Just over the COVID period, roughly 3 million jobs were lost, and sadly, women were mostly affected. And it's important to note that this is not only blue-collar workers. Even big IT companies like Dimension Data had to cut in a certain division 480 jobs, roughly a third of the staff in these two particular divisions that were affected through the Section 189 and so on. So this is widespread across all sectors of our country. And as a result, the patients that you see will not only have medical distress, but will have financial distress, and therefore, ultimately, as a result, the increase of bad debt risk. This quite made it real for me. This is the TransUnion. They do a lot of research on consumers and their kind of credit standing. And what they're doing really is running a financial impact survey almost on a weekly basis due to COVID-19. One of the questions asked in the survey was, what bills and loans are you concerned about your ability to pay? And so there's quite a long list of different categories. It's quite nice. It actually breaks it up across different generations, your Gen Zs, Millennials, Gen Xs, and your baby boomers. And it's quite interesting to see the different profile. Looks like baby boomers in particular, insurance and credit card is one of their big concerns to pay. But importantly, what made the top 10 list is medical bills. And you can see somewhere between 21 to 20 or 17 to 26%, particularly the baby boomers, those getting maybe a bit on and having maybe more medical conditions coming through. But importantly, medical bills was there straight after, just after internet, which these days is more important than oxygen and pizzas if you have teenagers like me. So medical bills highly rated there. Once again, emphasizing that practices really need to think carefully about bad debt risk. And then, of course, there's the risk of practices intermittently shutting down, as I mentioned, because either the doctor or staff has been affected. This is a screen grab out of our CRM system for our clients. Sadly, we've had to add a new category for a practice shutting down, at least temporarily. And as you can see there, this new category is COVID-19. And on an ongoing basis, we are seeing this. We have very clever systems that monitor the actual transaction flow rate that we expect on a daily basis. Excuse me.
Well, Louis, maybe while you take a little bit of a water break, we have some questions. So the first one is, and again, I don't know if you'll have this data in your head already, but in terms of the allied volumes, how are the psychologist volumes? So I remember actually I've been doing some data research now, and I did look at it, and psychologists did see an impact in April and May. Not as much as obviously other allied such as chiros. And I think specifically clinical psychologists, they actually probably saw the least impact. But don't quote me on that, but we do have an article coming out in a couple of weeks' time, which Doctor, I'll definitely send to you. And hopefully I'll have a little bit more insights into the allieds. I don't know if you have anything to add to that, Louis.
Yes, thank you. This is quite funny. Is there an ENT in the house? Yeah, so I looked at psychology volumes maybe about 3 or 4 weeks ago. And certainly they were more robust in general over the COVID period. And if you double click on it, you'll see in fact that those are one of the high users of TeleHealth. And so I think particularly because you don't have to be there with the patient and measure vitals and so on and so forth and do inspections, quite a few of them pivoted to use the technology word into the telehealth space. And so they were quite robust relative to others. But if you remember, across allieds, in fact, they were one of the most robust categories over lockdown. Cool.
Great.
Thanks for that, Liza.
Perfect.
Any other questions at this stage?
So I've got another one, but I know you do touch on telehealth coming up, but maybe let me throw it in here. If I'm using telehealth, how do I know it's secure for me and my patients?
Awesome. I'll address that directly if you allow me to get there just now. It's a very important question and a very important factor in your consideration. Great. Let me move on now. My throat is cleared. I was so taken back by the fact that we've got a subcategory of COVID-19. I lost my speech for a while. Right, and then of course on top of all this financial pressure is the health and stress risk for you guys as healthcare practitioners. Just worrying about yourself, your families, obviously your patients, and then the business of your practices. Thank you. I've just been brought some water. Somebody, I think my wife heard me choking to death in this room. And really, I mean, this is obvious, and unashamedly, I'd just like to take an opportunity to thank you all on behalf of us as Bridgens for putting your own lives at risk and your families at risk during this time where we really need you as a society and as a country. This is just a pick from Health Bridgens across the board in one of our campaigns. Right, so that was all doom and gloom. Trends tanking, all these impacts on practices. But the great news is, despite this, there is pragmatic steps that you as a practitioner, as the owner of your business, being a practice, can take against this COVID-19 pandemic. And I'd like to spend the next while just discussing this. And with a bit of tongue-in-cheek, unashamedly, I'd like to suggest that we don't have to wait until June next year for the vaccine for your practice. In fact, there are already 2 vaccines available that you can apply immediately to your practice. They've all been trialed, double-sided, double-blinded. They are robust and rock solid. And those 2 vaccines really fall in 2 categories. The first one being pragmatic steps to recoup revenues in a way that's not only good for your practice, but good for your patients and good for the schemes that fund them. And secondly, of course, is ways to either reduce, or if that's not possible, at least variabilize costs in your practice, so that ultimately the income statement of your practice, the revenues minus the costs, look better than what they perhaps are today. And I would like to go through a couple of themes on both of these levers, both of these vaccines. So the first one, and already it was brought up a number of times today, one of the opportunities that frankly is here over this time period is telehealth, is virtual consults at the end of the day. And why do I say this? It addresses some key and perhaps obvious challenges. The one being patients not wanting to come into practices, being scared, and particularly those with comorbidities. Secondly, no doubt, as we've seen by those graphs, there are 7.2 billion rands worth of spare consulting capacity, at least there were over the last 18 weeks. And so this presents an opportunity to make use of that spare capacity. Obviously, it's not applicable for every type of consult, but if you think of breaking up and perhaps stratifying the nature of your patient encounters, certainly we've seen that there's a sizable and material portion of consults that could be done through telehealth that don't require the face-to-face encounter. Secondly, if a doctor does have to self-isolate, well, then this presents certainly a great opportunity as well. It does provide for flexible hours, and these days certainly flexi hours is the name of the game in any industry. And at the same time, the good news is that there's growing patient readiness. I'm going to take a water again. I think the issue is that I've been so quietly working today, I haven't spoken and my voice is out of training. But this is a research commissioned by Philips. It was done last year. Little did they know what was coming. It's called the Future Health Index. And one of the key things that did research on was really the propensity of South African healthcare professionals and also patients to engage on telehealth. And you can see there that about a third, in fact, both a third of patients and a third of healthcare professionals last year before COVID were already predisposed to telehealth engagement. A little bit behind the 15-country average, but not significantly, in fact. It'll be very interesting to see their 2020 results come out, given what's happened and how those numbers have changed over time. What else can we say about telehealth? And this really points to one of the questions that was raised. Firstly, there are some hygiene factors that just absolutely have to be in place for telehealth to be viable for you as a doctor. The first thing is that it has to tie into your practice workflow. You've got processes where people either book appointments with you through maybe a range of mechanisms. They might have walk-ins, whatever. You've got a very clear process that after you've seen the patient, the paper file goes to the receptionist and the claim gets captured maybe today or the next day or whatever. But these workflow processes have been carefully thought out. And of course, now with either the patient not being present or in fact, perhaps not even you being present, that can pretty much upset things and create confusion in the practice. The next one is what you don't want to do is make a huge hurdle for the patient in particular and the doctor, but particularly the patient, to join the teleconsult. You have a range of abilities in your patient base, a range of ages, not just the Gen Zs, and so it needs to be super simple for the patient. Third factor, and this was raised earlier, is security. We've all heard of the horror stories of even Parliament being hacked during Zoom and so on, Zoom meetings. And so the security, particularly in line with the HIPAA regulations and so on, needs to be one of the important factors just to continue with the patient confidentiality that you offer to your patients and are legally bound to. And lastly, audibility. I can tell you, speaking to the CEO of a big administrator, one of the biggest concerns he has is, how do I even know this thing happened? How do I know? And there's a weird sense of security, which is really not rational, but if there's a paper file in the practice and I can go back and I can see that in fact this patient encounter was documented, then at least I know this patient encounter took place. And now with all these telephone calls and video calls, how do I even know this thing happened? So auditability is a very important factor. And so the workflows that one puts in between how the patient makes the appointment, how that appointment is confirmed, how that patient links into that encounter, that virtual encounter together with you, and as a result of that, how the bill flows and even thereafter payment reminders, because now you don't have a patient in front of you to collect directly, becomes very important. And so these strong workflows with security and auditability, and at the same time ease for your patient is really, we believe, a hygiene factor to make this successful and a pleasant experience for both yourself and for your patient. Hey, Liza, I see your camera's on. Nice to see you. Then there are two important factors to consider over and above the hygiene factors. And the first one is that it should be, ideally, seamlessly tied into the clinical notes that you take. It might be at a random time, in a random location. You might be housebound or so on. You don't have access to the big wad of yellow folders in the other room. And so now you take notes, you've got this piece of paper, how does that get brought back in? And so the ability to have access to the clinical notes, to append them, for them always to be available is incredibly important during the telehealth consult. And so something like this, where not only is the video between the doctor and the patient part of it, but a way to document that patient encounter and bring that back to the clinical records for that patient becomes a very important factor, we believe. Not a hygiene factor, but a great plus for you really to be able to treat the patient along the longitudinal timeline. And then the second important factor is, of course, patient follow-up. And that follow-up might in fact be done once again from a remote perspective. So, and of course, the big topic of today, of course, is COVID, but it's not just COVID. It could be a diabetic patient, a hypertensive patient. How do you keep track of these patients that you have treated? Now with this additional complexity of being virtual, how do you keep track of them in the COVID case? There's some steps that may have to be taken after that initial consult, depending on whether the result was positive or not, whether the patient was self-isolating, so on and so forth. And thus, a tool to be able to do this, we believe, is an important factor in telehealth going forward. Another important part, which really works, it's a beautiful place where it's firstly very good for the patient, and it's good for the schemes because it limits risk down the line in terms of big operations and big hospital encounters. And at the same time, it's good for you, the practitioner, because it helps you recoup patients, is of course those patients that are chronic and that haven't necessarily been to see you over this time for reasons being COVID. And there's all sorts of stats coming out as to how many more people these days are dying compared to last year that maybe aren't COVID related, but perhaps because some of the chronic diseases haven't been treated proactively as much as they should. And so therefore we see articles like this come out on a regular basis of late. And so again, tools that allow you to proactively come out to these patients. You'll see an example here, not seen within the last 6 months or 3 months or whatever the last visit, perhaps entering in certain diagnosis codes, your diabetic patients, your hypertensive patients, wherever, what, not. And then based on that, putting together emailers campaigns and SMS campaigns that basically say, hey, Louis, noticed you haven't been here in the last 4 months. I know things are tough and COVID's around, but as a diabetic patient, it's really important that you come up for your follow-up so that we can check that your meds are still working, check out your sugar levels and so on and so forth. And of course, and if you'd like, and you're a bit nervous, maybe at least even a virtual consult will be the way to go in the meantime. So again, a great space where not only does it help you recoup revenues, but in an ethical way, because these patients need to see you. And in fact, schemes would be very happy if this were the case, because they want to avoid the downturn or the down the line costs that will be a lot bigger than their patient encounter. This one is not so much recoup revenues, but maybe recoup costs. Claim for PPEs. You are incurring additional costs in masks and gloves and hazmat suits and all sorts of other things. The great news is that there is schemes have come around and are prepared to pay for those PPEs and help you recover those costs. I was just speaking to a head of a big doctor grouping just the other day, and in fact, not only is it Discovery who took the lead, but in fact, there are a number of schemes that are shortly coming online that are prepared to pay for PPEs. It is a bit of a minefield. There's all sorts of complexities, and every scheme has got a different pricing model on how to do it, and you'll be left with the situation of how do I portion my 1 mask per day across my patients that come across different schemes. Your billing system ultimately should be on par with this, with the latest information, and help you with the appropriate billing based on the patients that you see and the schemes that they belong to. But again, these are additional costs you're incurring, and no reason why you shouldn't claim back for them, particularly now that schemes have said, yeah, absolutely, we'll help out. It was an unbudgeted expense, but we'll do the right thing. And then lastly, a way to recoup revenues is really to embrace the online reputation. Given that patients are looking for virtual consults, they no doubt are going to go to Google and other places like that to look for opportunities to see a patient or see a doctor that does treat online. So more than ever, your online presence is very important for your practice. Certainly there are good tips and tricks and handbooks on how to get your medical practice to rank on Google. When I search Dr. Inbel, for example, how does my name come up? And also different strategies on how to get your presence online if it's not there already, or maybe enhance it. Given that patients will be looking for doctors that can treat from a virtual perspective, and those might in fact be patients that you haven't seen in the past that are new. Then in terms of reduced costs, and the first cost that I want to bring attention to is bad debt. It's still amazing to me that after 20 years, when we were so excited that we had brought around this concept of a real-time claim, where you could claim while the patient was there at your practice after the consult, the bad debt risk of practices on average is still at about 10%, which is startling. We see practices as low as 2%, but on average, there's still a big bad debt risk component. And why is this?
Louis, sorry, I actually think it's probably a good opportunity just to answer a few questions just before you go into the reduced cost aspect. So the first one's a little bit of a long one. There's a few questions in there, but it's how can you really do virtual consultations and know it is something that you can do virtually? When you realize that you need to see the patient, do you bill him again? What about time lost, patient's funds depleted, and private players? And I think for me, like probably the good question is how do you collect virtually?
Yeah, so if the question is how do you collect virtually, then ideally the system that you use should be able to document the patient encounter, and as a result of that, know that it's a virtual consult. In other words, when the appointment is made, it's already flagged as a virtual consult, which as a result, the bills are very specific codes. I won't get into them, the 0130s and so on. And that should be sent off immediately to the scheme. And then, of course, should there be outstanding monies left over, because maybe the benefits have run out, then of course you need a proper strategy in terms of collecting. It really plays into the very next slide we're about to talk about, is that it doesn't help to send any claim, be it a face-to-face claim or a virtual claim, 2 weeks after the consult, after date of service. The faster you submit and the faster you follow up, it is well known and well documented in any debt collection strategy, not just in healthcare, that your chances of collecting monies drops exponentially with every day that goes by after the service is rendered. So it's really about being able to have a conversation with that patient, ideally while the injection is still a little bit sore, bruised on the right shoulder.
Yeah, and I think maybe it's also about like employing sort of techniques that are digital. So for example, maybe like SnapScan to collect payment.
Yes,
just to make it faster as well and easier for patients to pay.
Absolutely. There was some good research that came out in the US that really tried to unpack why patients didn't pay outstanding monies to doctors. And, a very small percentage is actively because I planned not to pay the doctor. We, as consumers, as humans, tell ourselves a story of why we'll do it another day, or we tell ourselves a story, this doesn't make sense, let me see what my medical aid says, particularly if the bills aren't clear and aren't timely, and it goes into that stack where to do sometime and patients never get there. Those are really the big categories. Of course, with the financial pressure, that makes it even more challenging.
Perfect. Cool. And then we just had one other one. I can't keep up with the updates from medical aids about how much they'll pay for things like telehealth and PPE.
Right. Great. So there are two sides. The billing company that you use should be sending out circulars as soon as there's news, much like you saw the one about discovery and PPEs. And then the billing system you use should automatically update its pricing files to include the latest prices as schemes change. I know in the case of HealthBridge, on a weekly basis, there's a new price file that gets updated onto our cloud systems based on the latest changes that are made. So it's important that that pricing file, however you are managing it or whatever you subscribe to, is a good one that keeps these prices up to date. But at the same time, you need to know that in fact, for example, you can claim for PPEs. That sometimes comes from the scheme directly. It might come from an association you believe or that you belong to, but certainly it should come from a proactive billing system that says, hey doctor, just heads up, so-and-so is now available, or this and this has changed. Just like a scheme would change to a different administrator or whatever, you need to be notified of that, and of course you need to read those circulars that go out. That's really there, and there is a lot happening, particularly now in the space of both virtual consults and now in PPEs, and it's a bit of a jungle. Every scheme is thinking about it differently. There's no standardized way, and thus you really should be looking at your billing system provider to take away the complexity for you.
Great. Then we have one going back to telehealth. So medical fraud is a reality. How can I be sure the patient you're consulting online is really the patient stated? In my practice, we check ID and membership details and correlate. I'm sure the medical aides have had to consider this.
Yeah. So again, ideally the way this should be created is that an appointment is made by a patient. That appointment is noted through your online calendar, and that online calendar accesses your patient database. So there should be no surprise that Liza De Beer has asked to see you, because already she should be in your patient database. The only cases where that becomes tricky is obviously when it's a new patient that you haven't consulted before. And there, I think it's very important that when that encounter is registered in your calendar, in your online calendar, that's flagged for your staff to request things like copies of IDs and so on and so forth. At the very least, you have the auditability that you collected the information, that the consult in fact did take place. And again, as I mentioned earlier, your system should be able to log that and be able to report on that so that you can show that as proof in case there's any query coming back from the scheme.
Perfect. Great.
Thank you, Liza.
I just noticed your battery is running a little bit low. Hoping we're going to still survive.
Oh, wow. Thank you. How did you see that?
I actually got a little tip from somebody.
Thank you. So let me confess right now, I'm normally relegated to the room on the other side of the house, which is an southeast facing room behind a big wall. It is like walking into the fridge of a butcher the whole day. And by the end of the day, I'm literally shivering. So I've moved into the other room, which saw a bit of sun during the day, where my wife works from. And in doing so, I forgot to power my laptop. Thank you, Liza. I don't know how you did that, but that's very cool. And you'll be glad to know that the power supply is plugged in. I don't know if you can see it at all.
Yes.
Okay, awesome.
Cool.
Okay, all right, let's go on. We've got 8 minutes left and not too much to cover, so I think we'll be on time. I was talking about reducing bad debt, and really one of the key things, as per the question that came up, is be like a pharmacy. Before the patient leaves the pharmacy, exactly everybody knows how much is going to be paid and the monies are outstanding, particularly for the face-to-faces, which we know, despite speaking a lot about virtual consults, it's still over 97% of all encounters on average as we speak today. So send in real time and collect outstanding monies in real time. And this, to be honest, this next graph is quite disheartening for me. I feel like my job's not done at HealthPitch, because we introduced real-time claims as early as September 2000, and still over the last few weeks, this has been the trend. On average, our general practitioner clients are taking 7 days between date of submission and date of service. On average, they are sending their claims 7 days after the date of service. Specialists 12, and you can understand there's a few authorizations and motivations that need to be done, so it should be a bit longer. Dentists 6, optometrists that are really retailers 5, and the general allieds as much as 15. Yes, you psychologists and other people that are here today. 15 days. And this, frankly, just sets you up for bad debt. If you send it in 7 days, then there's maybe that patient has run out of benefits. Then you got to chase the patient, and who knows how long it takes before you know that the amount is not going to be paid, versus when you send out for the money to be collected. By then it's 14 days, 21 days, and the patient goes, "Doctor who? When?" Doesn't even remember anymore. And so this is definitely a way. These numbers should all be 0. The same day of submission should be the same date of service. And there are technologies around that allow for this to happen in systems. So maybe me imploring upon you to radically change this, and you could easily reduce your bad debt by at least 5 to 7% by just 2 years. Another important aspect is move to cloud. It's now cheaper than desktop. If you think about the total cost of ownership, including backups and the risk of data getting stolen and all sorts of things. It is safer. The reality is these big cloud areas are safer than making backups on your desktop these days. And it's fast. These days you've got some really good internet connectivity. So all in all, a move to a cloud system really leaves you light and actually safe and secure these days, as counterintuitive as it may still seem to some people. Other advantages, as we spoke just now, it keeps you up to date with the latest industry changes. When that next PPE price comes in, guess what? The next day you log on, that price for the Bonneter's XYZ scheme PPE price per glove will be there. And it will be just by default. You don't have to go and update it yourself or wait for certain updates and do it. And then, of course, the great thing about cloud is that you start getting an ecosystem of cloud players that start coming together to join up and offer you a range of value adds. Liza mentioned SnapScan. That integrates directly, certainly with our cloud solution, a whole bunch of different things that you can seamlessly add in and customize the blend of services that you want on a very easy basis without major onboarding costs and training and so on and so forth. And here I want to give some two great examples of practices who have taken the leap and the benefits that they've got. So this is Dr. Lee, and with her permission, we've got a quick synopsis. She moved around about April in the middle of the COVID pandemic. And over the period from the 17th of April to the 12th of June, she has flipped her practice to a point where I think 53%, if you look at that middle graph, 53% of her consults have flipped to virtual, either through video and telephonic, and in fact video a lot more. And I want to quickly read what she said, and I'll leave out the health pitch word because this is not a health pitch punt, but the telehealth solutions work like a charm for me and my patients. It's tackling many of the problems that COVID-19 has brought with it, like reducing stress for patients as they don't have to come into the practice. Not to mention the fact that it's cheaper and saves on petrol costs. It also saves on precious time too. They arrive and I arrive in the online appointment when we both need to. We get a great picture quality, so we get focused on the appointment and not on the technology. One of the other things that I enjoy is being able to work from home. This has helped my secretary too, as she's online and it's easy for her to book my appointments into the calendar, and on the billing side of things, really easy for her too. I like that telehealth can be used with any medical aid. It's also robust, it just works. I'm a Mac girl, and the fact that this doesn't only work for the Android crowd impresses me. Certainly with a lot of negativity circulating lately, telehealth has in a way kept me positive about my own business. I can just keep doing what I need to do and run my business. Even in the future, I will definitely keep using telehealth. This technology gives me more flexibility, as I've often thought about how I could work from home even more. When I think of the big picture possibilities, it's fulfilling for me to consider the opportunities for rural populations too. This could allow them access to medical care and avoid costs of travel. So this was from a GP, Dr. Lee in Durban. Another GP in Durban, Dr. Kathra, sounds like KZN is leading the charge here. Telehealth, really easy to use. We were shut down and we were shown how to use the system in only a few minutes. Then just a few hours later, we were testing with our first appointments. I love that it's easy for my patients to use as well. It's just as simple as click from an SMS or an email. New page opens on their browser and we're off. No hassles with permissions or account setup. I can definitely see this, and this is consistent with many people, using the system into the future too. In other words, not just during COVID. It's been a great help since the arrival of COVID-19, but this will be useful for me too in other ways. I can be anywhere in the world on business or holiday and still look after my chronic patients who need me. So two great examples of this.
So, Louis, I think, we're seeing with these doctors how telehealth is really helping them. But one of the questions received was, why would medical aids reimburse almost 40% less for telehealth consultation?
That certainly I've been involved in exchanging with some role players in healthcare. The argument started off saying, well, typically those consults are shorter and they don't incur all the costs that a face-to-face do. Now, if you take PPE out the equations, because that was before the time, I mean, your fixed costs are not going to go away. What we are seeing is a big divide in how schemes have responded to this. Some have not just kept the price, but in fact dropped the price. Others, however, have gone and said, listen, doctors, thank you for looking after our members. We realize you're under strain. And in fact, depending on what contract you're on with us, we'll pay you up to the full face-to-face consult. So there's a myriad of schemes that have approached this in different ways. Frankly, some have tried to force their hand on other strategic objectives that they may have. But there is a wide, like I said, both the TeleHealth and PPEs, it's a bit of a jungle out there right now in terms of how different schemes have responded to it. So yeah, a valid point being made, and certainly from our side, we are doing everything we can to get schemes and administrators to look at it differently and to pay the right price.
And then just another question, will the change in telehealth regulations revert back after COVID-19? I'm not too sure if you've got clarity on that. I know it's still quite a debate topic.
It was another great question. There was, thank goodness for the national state of disaster and the fact that certain ministers have got power, because I think that may have brought a bit of influence. Of course, SAMA is very concerned about the abuse that could happen in telehealth. And so it is understandable. And certainly the regulations that were adjusted say that after COVID, things would go back to as per what they were initially. It remains to be seen. Hopefully, one will see that this has been a great benefit ultimately to patients and to the profession, and therefore, hopefully post-COVID, this will stay in place going forward. But that remains to be seen. I think what certainly caused SAMA, rightly so, to rethink the situation was the gravity of the situation in terms of access to doctors for patients. But hopefully the positives that come out of this will allow for the, sorry, not SAMA, the HSPCA will allow for the regulations to stay in place thereafter. Cool. I'm wary of that we just passed time. We've got a few slides to go, so maybe let me go through it quickly. We're talking about reducing costs, and EMR and digitizing obviously gets rid of patient files, filing cabinets and paper filing costs, which start building up over time. And importantly, costly floor space, which maybe is an opportunity cost that could be used for other things, like maybe having an in-house nurse or something like that instead of filing cabinets taking up space. And then, of course, a good EMR should give you accurate and complete billing straight after the patient encounter, and of course access anywhere on time. It's important to note that this is an evolution. We started off with paper files. Now we're in the days of, yes, you can get access to these records either through your laptop or mobile devices, but the journey will continue to really provide good access at low cost. In the end, we see teams of practitioners working as a virtual team, sharing the appropriate information with each other within, of course, the guidelines of regulations. And so we really think it's good to start on this journey, because certainly this concept of EMRs is going to evolve. It has to, just to bring down cost and proper access as much as we can, given the needs of our country. So yeah, certainly urge you to start the journey. Another way to maybe not reduce costs, but variabilize costs, is to align your suppliers with your revenue. There are billing systems or solutions out there that will charge a percentage of revenue versus a flat fee, which means that if your revenue drops, then so will your bill. These technology partners drop too. And it might also be a time to consider a bureau. If you have a disruption in staff, maybe somebody has resigned or has left or retired or so on, this might be a good time to consider a bureau, because again, typically they would charge as a function of revenue. Whoops, I hit the wrong button. and there might be the possibility of removing some fixed monthly costs in terms of staff costs under this, or at least reducing the number of costs for using the bureau. So that's another consideration. And of course, these companies typically have got good bad debt collection strategies and services which address the other issue we spoke about. And lastly, and only if really, really necessary, consider bridging finance as an interim step to get over that hole that we spoke about earlier and to get your practice back on track. Of course, it comes at a cost and a great risk, so please consider it carefully. There are some great options, this one particularly from Nedbank, where up to 200,000 Rand unsecured loans at Prime +1 is I think, a very good deal. Of course, with the bank, there's quite a lot of hurdles and all sorts of paperwork that needs to be done, but worth considering. There are other options as well, where certainly from our perspective, with a track record of good business practice, we've been able to partner with people that can give a pre-approved loan for a certain amount of time, just based on understanding the revenue flows through a practice and getting a sense of how well the practice works operationally in terms of collecting money, and therefore can risk rate it differently and hopefully offer something that's appealing. So I've spoken a lot, sometimes choking. In conclusion, what are the key takeaways? I think the first thing is the storm is here, as we know. It has an impact on the practice. Not only has had an impact, but we can expect the impact to continue for a while to come. And this, of course, presents key financial risks to the business of practices. The good news, however, is that there are actionable strategies, and we've gone through a few that either talk about how to ethically recoup revenue or otherwise to reduce or otherwise variabilize costs in your practice to weather this storm. And that really is the summary. I'm going to leave you with one slide. I believe it wasn't he who said it, but maybe got allocated the fame or claimed fame, but the typical Darwinian quote, it's not the strongest, but the most adaptable that survives, I think is very applicable for all businesses, including your businesses right now, the business of your practice. And hopefully what you've seen today is a couple of options on how to adapt so that you not only survive, but in the end thrive as a practice. And from our perspective and from the rest of the Health Pitch team, a great big thank you for attending today. We hope it was informative. And as Liza mentioned, the certificates will go out in the next few days for attending this webinar. Liza, I don't know if there are any last minute questions.
Yeah, just quickly, I've just popped a link into the chat box for the HPC SA evaluation form. If you guys can please fill it out. I know we have gone over time, so if you are in a rush, just look out for the email that I'm going to send with your certificate. It will also contain a link to the form there that you can fill out then. But yeah, just hope that tonight's topic was interesting and insightful, and I hope it'll help everyone navigate these truly unique times. So yeah, from us at HealthBridge. Good night, everyone.
Thank you, everyone. Have a great evening. Bye-bye.
Cheers.